Hi everyone, this is Dr. Mitali. I'm the speaker for today. I think we'll wait a little time for everybody else to join, whoever wants to join. Meanwhile, in case anybody else has any questions or if you guys want to talk, please unmute yourself. Go ahead, let's talk if you guys are interested. I'm a very talkative person.
Hi, Dr. Mitali.
Saraprit sir is there. Hello, sir.
How are you? So please ensure that it's recording. That's something very
Sir,
important.
it
Yeah.
is recording. It is recording, sir.
Okay, you have to make me the co-host because I have to present the basic information. I'll just check whether I can. You also check whether you can share your screen here.
सर हम एक बार शेयर कर रहे हैं, आप देख लीजिए अगर हो जा रहा है। पहले हम शेयर कर रहे हैं।
Okay,
स्टार्ट
okay.
ब्रॉडकास्ट। एक ही सेकेंड। यस सर, शेयरिंग।
Yeah, I can see it. Yeah, फुल स्क्रीन करके आप बस
ओके।
चला। एक बार
हाँ
मैं
ठीक
भी
है
देख
सर, फुल स्क्रीन ही
लूँ।
है।
I have to brief them about the basics and थोड़ा सा मैं बताऊंगा
ऑफ कोर्स।
about
हाँ
the
श्योर।
basic courses which we are. तो उसके बाद आप शुरू कर लेना।
हम्म।
Yeah, so you can
श्योर
stop
सर, अभी हमने
sharing.
बंद कर दिया शेयरिंग। हाँ डन सर,
Yeah,
डन।
10 मिनट वेट करते हैं, 5 मिनट.
श्योर सर।
अभी we are expecting some more people also. और मिताली कैसे हो? You have done prepared a very nice
बस
presentation
सर।
also. Yeah,
थैंक यू
time
सर, आई
time.
होप लोगों को मजा आए एंड हमें खुद हंसी आएगी, आई एम श्योर। स्टैंड अप कॉमेडी नहीं करनी है बट
I mean, everybody is going to gain a lot of information is there. Yeah.
Yeah, definitely, sir. And it is important for people who come into contact with pregnant people anyway, चाहे family में हो, relatives में हो, friends में हो, या obviously as patients हो. So it's a good topic. It's very important. And MBBS में
Very.
तो हम लोग नहीं पढ़ते हैं ये उतना. Yeah,
हाँ, कुछ भी नहीं पढ़ते हैं बीबीएस में तो मतलब हम.
true.
And these topics are little awkward for MBBS people. But it should be taught. They should be primed about all these things.
Exposure is important, so definitely.
Important, very important. So we've got 24 people logged in. So I think
Already.
uh, 3-4 मिनट में शुरू करते हैं बस, है ना? I think we have a decent
Sure,
audience.
sir, sure. Hmm. इस टाइम पे आई थिंक इट्स आफ्टर वर्क आवर्स फॉर मेनी एंड शाम का ओपीडी आवर्स फॉर अ लॉट ऑफ पीपल।
If you think that we should change our timings, we can start at
ना
7:30,
ना
8 or
सर, जस्ट फॉर टुडे, वो तो बाद में देखते हैं, डिपेंडिंग ऑन व्हाट द पीपल फील ना,
you,
उसके हिसाब
you,
से वी कैन वर्क ऑन दैट। आई एम ओके विद दिस टाइम सर। हम म्यूट करते हैं
yeah,
सर।
good 1-2 hours of. Now with the presentation, I hope my voice is clear. You can see my screen clearly. Mitali, can you hear me?
यस सर, आपने जो
Mitali, can you
स्टार्ट
hear
किया
me?
है। यस सर, आई कैन हियर यू।
Fine,
हाँ बस अब स्क्रीन आ गया सर। ओके सर।
fine. Let me just, yeah. So is Rashmi also around? No, Rashmi is not there, ना? उसका किसी और नाम से आता लॉगिन उसका रश्मि का ना. Anyway, so we are going to start the session for today, and before that, we would like to introduce about the Fertilis Academy and the courses which we are offering. We are primarily dealing with the reproductive sciences as well as sexual health being a very important component of the reproductive sciences and infertility management. So we are also focusing on sexual health and medicine. And we have come up with the two courses, basic and the advanced course on sexual health and medicine. It's a series of lectures which will be part of this course. First, if you look at the basic course, it's named Essential Concepts in Sexual Health and Medicine. And we focus on the understanding, diagnosis, and treatment of sexual health challenges And we want to give you the confidence that, which we have been missing till now. Most of us will, have hesitation in taking sexual history because we cannot treat it. So why to take history? As well as we are not very comfortable doing it. So this will be, focusing on a lot of things which we have not studied till now. And we start on 15th of January with the basic course. We focus on the anatomy and physiology of sexuality, go on to the neuroendocrine pathways which influence sexuality, and the very important topic, sexual response cycle, then sexual disorders, DSM versus ISM classifications. Then most important topic, I think it's pharmacology of sexuality, and we've got very senior people coming in. We have got Dr. Rashmi, we have got Dr. Divya, we have got Dr. Mitali, Dr. Anita is with us, Dr. Manohar is with us, Dr. Adarsh Tripathi is with us. So we have got many stalwarts of this field coming in and taking sessions in this course. Then Dr. Divya is going to talk on gender identity, orientation, and culture. And very important topic, history taking, will be dealt with by Dr. Rashmi Patil. Then we'll focus on a broad overview of male sexual dysfunction and female sexual dysfunction, and followed by masturbation, very physiological, and but it's a lot of socio-cultural issues, and there are perversions in masturbation, and as well as socio-cultural syndromes like Dhat syndrome will also be dealt with. Finally, we end the session with clinical vignettes, which will be discussed by Dr. Manohar. He'll be taking the lead in this, and we'll be open to answering any questions which you have. So, all through the 10 session program, as well as in the end also. So, this is about the basic course. If I come to the advanced course, the dates will be announced very soon. Most likely, we'll be starting this course in March, and it starts with again history taking, physical examination, sexual dysfunction in various psychiatric disorders, how to manage them. We'll be focusing on substance use, alcoholics, medical disorders, and the related sexual dysfunctions. We'll be focusing on specific topics like erectile dysfunction, premature ejaculation, psychosexual therapy, genitopelvic pain disorders, dyspareunia, vaginismus, etc., and medication-induced sexual dysfunction, genital hygiene, commonly transmitted sexually transmitted infections. And we are getting Dr. Murugan, who is one of the very renowned persons in this field. He'll be taking the skin sessions. And then the thing which is affecting everybody nowadays, pornography, online, digital media, social media, and its effect on sexual dysfunction. And finally, we end with female sexual dysfunction, and Dr. Mitali will be dealing with those sessions. And ultimately, like in the basic course, we will be taking on the clinical vignettes and complications managements, most relevant, most pertinent cases, as well as always all the sessions will be followed by a lot of question and answer sessions. As part of this, the preview or a build up to the basic and advanced course, we've done one lecture with Dr. Divya on menstrual cycle, libido, and mood. It's available on our YouTube channel. It's also available on the app. So don't forget to review it whenever Next session is going to be taken by Dr. Mitali Srivastav. She's a MD and a fellow of psychosexual medicine, and she'll be talking on sex and pregnancy. Two more sessions are lined up by Dr. Rashmi. She'll be talking on approach to a patient of sexual dysfunction, and that's on 8th of January, same time, 5:30 p.m. onwards. And Dr. Atmik, he's a sexologist. Dr. Rashmi is a psychiatrist and special interest in sexology. Atmik is a sexologist. He will be talking on counseling in sexual medicine. So you get a very comprehensive idea about how to approach a patient, how to take history, physical examination, and finally, Atmik will be talking on counseling in sexual medicine. So this is a complete spectrum of demo classes which we are offering as a build-up to our course of on basic and advanced sexual medicine. Now I'll go on to have the privilege of introducing Dr. Mitali Srivastava. Dr. Mitali Srivastava, she has done her MBBS and MD biochemistry from Pondicherry University. When she passed out, she found that there is a huge vacuum in the field of women's wellness, especially in sexual medicine. So she went on to pursue Dr. Mahinder Vatsa's correspondence course in 2017, and she's probably amongst the first Indian to achieve the uh, hugely acclaimed European Society for Sexual Medicine school training at Budapest. And she also went on to do a fellowship in psychosexual medicine from JSS University, Mysore. And she has always held this passion for women's wellness, relentlessly working to create awareness about sexual health in women and couples. And she runs her own hospital in Ahmedabad by the name of Sheetal Women's Hospital. And she is one of the front forerunners in women's sexual wellness in the area of her practice. And she is coming to the national as well as the international scene now that she is a ESSM graduate also, along with her fellowship from Mysore University. And she will be speaking on sex and pregnancy. So please don't miss out this opportunity of listening to Dr. Mitali. Dr. Mitali, over to you, and thank you so much for being with us. And
Thank you,
uh,
sir.
the stage is all yours.
Thank you, sir. Sir, my screen is visible?
It's visible. You can enlarge it if.
Okay,
Yes, ma'am.
okay, थोड़ा ही जाएगा. Yes. All right, great.
Yeah.
Hi everyone, this is Dr. Mitali, and I also call myself the Besharam doctor because I'm बहुत ही बेशरम इंसान है when it comes to patients. So today I'll talk about sex and pregnancy because I work in a women's hospital. तो मेरे सारे patients जो होते हैं वो pregnant patients होते हैं obviously. मेजोरिटी ऑफ देम या प्लानिंग प्रेगनेंसी या पोस्ट प्रेगनेंसी गायनिक पेशेंट्स भी होते हैं बट मेनली एज यू नो इंडिया में वुमेन्स हॉस्पिटल मतलब जहाँ पे डिलीवरीज होती हैं तो हमारा भी वैसा ही एक हॉस्पिटल है अहमदाबाद में सो आई डील विद अ लॉट ऑफ प्रेग्नेंट पेशेंट्स तो एक्चुअली व्हेन आई
Mitali,
स्टार्टेड तो
I'm sorry to interrupt, but there are a lot of international students also. So
oh so let's
it
not go
is
to
better,
Hindi.
yeah, better,
Okay.
yeah.
Sure,
Many
got it.
international students.
Okay, sure. Let's keep this only in English. So, what I was saying is, I practice in Ahmedabad in Gujarat, and I used to practice in a rural area. So, now in a rural area, I used to see a lot of patients, pregnant patients, and occasionally seeing a lady doctor sitting in front of them, they would ask me about doubts they had about sex, and I had absolutely nowhere to refer them. I had nobody to ask for guidance. So that is where, almost around, I think, some 8, 9 years back, I started preparing to answer these questions. And that is how I came into sexual medicine. So, sex and pregnancy is a very important topic for any practicing clinician because you will deal with pregnant patients regardless of the field that you're in, whether you're in internal medicine, whether you're in pediatrics, whether you're in gynecology, urology, surgery, wherever you go, you will find sex and you will find pregnancy. Let's get on with it. So this is a very recent snippet. A couple in their late 20s who had a 2-year-old child. So they had recently reactivated their sex life and had become pregnant again. So the husband was very regretful, kind of sad, and the wife was kind of shy. So they said that we abstained for 1.5 years. There was 9 months of pregnancy and 9 months while the baby was small, and they were busy with parenthood. But recently, on many porn sites, pornography sites, the husband saw a tag, pregnant and pregnancy. So they asked, can we have sex even in pregnancy? So this is, if you see the tags on pornography sites, this is on the site Literotica. It's a reading, pornographic reading site. So you'll see the tags pregnancy and pregnant. I've highlighted that. And that is from where they had the idea, oh, it's possible to have sex in pregnancy. So now I would like to know, should you have sex in pregnancy? What do you guys think? You can answer in the chat. What do you think? Can you have sex in pregnancy? You can unmute yourself and you can answer. Can you have sex in pregnancy?
No,
Is any
ma'am.
no? Okay.
Yes, if
Okay.
it is not
Any other?
contraindicated.
Not
Unless
only
it's not
sex.
contraindicated. And so you all think that unless it's contraindicated, right? Many of you think it's unless it's contraindicated. Uh, yes, you are right. Hmm. Anybody else?
Yes, pregnancy.
Okay, you can have sex in pregnancy. You can have sex in pregnancy, but the correct answer here is unless contraindicated. That is the correct answer. Of course, you can have sex in pregnancy, but should you have sex in pregnancy? It is unless it's contraindicated, right? Then, in which trimester is sex a no-no? In which trimester should you not have sex? It would be better if you guys could unmute and answer because I'm screen sharing. In which trimester is sex a no-no? First, second, third, none of the above.
First trimester and third
In
trimester.
the third
None of the above.
trimester. Third
For
Okay.
me,
trimester.
none of the above.
C.
Okay,
None of
so
the above.
somebody who's saying none
You
of
can
the
have
above,
sex
those who are
in
saying
the
none of
third
the above
trimester.
is right. None of the above is actually the correct answer. You can have sex in any trimester. Imagine for a lot of people who don't know that they are pregnant, they go on to have sex, right? And they don't know they are pregnant. They discover it when, it's like 2.5 months. Nothing happens. Nothing happens. Again, unless contraindicated, unless you know that something is wrong, or sometimes pregnancy is discovered after somebody's had sex and they were actually pregnant and they have bleeding, and then they find out, oops. So the answer is none of the above. Again, in every trimester, you can have sex, but only if it's not contraindicated. Which is the hottest trimester of pregnancy? Hottest, horniest, most exciting trimester of pregnancy? First, second, third, any trimester in the month of May or summer months. What is the correct answer?
Third trimester.
Third
I said
trimester?
Third trimester, yes.
No, it's not the third trimester. Maybe for the partner, maybe, but definitely not for the mother.
I go with D. Any trimester.
That's a good choice, but the correct answer is B. It's the second trimester. And we'll find out why it is the best trimester if you are planning to have sex in pregnancy. Again, this also is conditional. If it is not contraindicated, that is when you'll enjoy good sex in the second trimester. So now we talk. So sexuality during pregnancy is shaped by multiple factors. There are biological factors, there are psychological factors, environmental factors, and relational factors. We'll see what each aspect is. So biological factors include obviously the medical complications. They include medical conditions of the mother. For example, placenta previa, BOH, that is bad obstetric history, preeclampsia, hyperemesis gravidarum, and multiple pregnancies, etc. Placenta previa is basically a low-lying placenta, so that can cause easy bleeding upon penetration. Bad obstetric history would include a medical history where there have been multiple miscarriages, where there have been early deliveries, preterm labors. Preeclampsia would be a risk of hypertension. Eclampsia is full-blown hypertensive crisis in pregnancy. So preeclampsia is preceding eclampsia, and even the risk of hypertension. These are all complications that can happen in pregnancy. Hyperemesis gravidarum, a lot of vomiting, a lot of nausea. Obviously, the mother is not going to want to have sex when she's vomiting all the time. Multiple pregnancies because of their chance for early labor, preterm labor, etc. Obesity. Obesity by itself causes low libido, causes poor desire. So, what happens in obesity in a pregnant mother is her body is growing even more. The positions that you need to attain during sex, they become even more uncomfortable. Fatigue. Fatigue is the number one cause women avoid sex in pregnancy because it's so tiring. They're already so tired. You get up in the morning, you're not fresh, you're tired, you're so tired. Sex is nowhere in your mind. If the mornings are like this, imagine after a full day of work, you're not going to be feeling into it. You're not going to want sex. Nausea. You're having nausea and your partner's approaching you. Let's have some good times. No, not happening. What if you vomit during that? Obviously, a nauseous woman, a woman who's vomiting, is not going to be interested in sex. Lower backache. Lower backache by itself is a specific condition on its own that can cause low libido. That can cause because it's a risk factor for depression. It's cumbersome. It's exhausting, and lower backache in pregnancy is all the more worse. That again with the positions and with the effort that it's going to take, lower backache also takes away from the pleasure. It becomes cumbersome. Some of the psychological factors include anxiety, stress, Anxiety and stress about the pregnancy, anxiety and stress about any aspect of their lives, be it financial, it could be familial, it could be work related, it could be anxiety about the future, pre-existing depression, any sort of psychiatric disorder, psychiatric difficulty that the patient has been having since before pregnancy will need attention even during pregnancy. And these things and their treatments make sexual desire low. Then mood disorders, history of traumatic pregnancy or birth. The fear increases multiple times, multiple fold, because there's been a history of a miscarriage before. There's been a history of traumatic birth, the history of remembering how the delivery happened or if it was very traumatic. These birth traumas or traumatic birth, as it is called, it could be traumatic for the mother as well as the father. It's not just the mother. Remember that even partner trauma can happen. And then there are medications impacting sexual desire. Sexuality during pregnancy is also shaped by environmental factors. For example, the household atmosphere. It's a dysfunctional family. It's a pregnancy where the husband and wife are on the verge of separation. It's a family where there has been a death in the house. It's a family where the child, it is, a child is a special needs child, and it takes all the more effort to run a house. And it could be work pressure. There's no support, there's poor support at work, there's not much support that is incoming for a pregnant woman. It could also be the physical aspect of the work. For example, a sedentary lifestyle. For example, a lot of running around. For example, standing ICU nurses. For example, my patients, a lot of them are ICU nurses, nursing staff. So they have to stand a lot, and by the end of the day, with the mental and the physical load that they carry, this is an example. It's a lot. A sedentary lifestyle and family harmony. You're on good terms with the husband. You're not on good terms with your sister-in-law, and she lives with you. It's going to cause difficulty. Financial comfort and financial stressors are also going to complicate your desire to have sex. Security, emotional, financial, as well as safety. These are all important factors that can impact how a woman feels about sexual desire, how invested she is in her sexual well-being during pregnancy. Then there are relational factors, which are very, very important. The relationship with the partner per se, and the desire for parenthood. What if it's an accidental pregnancy? What if it's a pregnancy she did not really want? So there are conflicting feelings, a lot of guilt, a lot of shame, a lot of blame, and the number of previous children depends, and the past history of relational disturbances. For example, the history in the previous pregnancy is that the husband was not very attentive, they used to have frequent quarrels, stuff like that. So that again is going to cause apprehension anxiety. It's again going to make the woman vulnerable, and she can lash out, she can feel low because of hormones, because of moods. And this is everything, all of this is going to impact a woman's desire to have sex. Sexual activity is generally considered safe in uncomplicated pregnancies. A majority of the pregnancies that we see are uncomplicated. Most of the changes that a woman faces when it comes to sexual well-being are trimester specific, and these are influenced by the symptoms that happen in each trimester. For example, there's the nausea, there's the fatigue and pain. Now, fatigue is a permanent feature of pregnancy, that I can tell you. Then body image, stress, and relationship dynamics. Relationship dynamics often change during pregnancy, with the father becoming more attentive, and that is a positive aspect. Or sometimes the father is not attentive, the father is irritable, many things. But it is the father is something that the mother does not want at that moment, and that's going to impact it negatively. He's an attentive husband, he's caring, appreciative, acknowledging. It's going to be a positive, nice, positive relationship. So, what stops a woman from desiring sex in pregnancy? It could be a personal experience, or this is something you must have heard from your partner. You could have heard it from a patient, from a friend, a sibling. It could be anything. So, what do you think stops a woman from desiring sex in pregnancy? You can unmute and you can tell me. What stops a woman from desiring sex in pregnancy other than fatigue and nausea?
Fear or anxiety about the safety of the pregnancy.
Very nice.
If a woman is already pregnant,
Yeah. Oh no, if she's pregnant, yeah, obviously if she's pregnant, but what is stopping
Fear,
her
fear
from
of,
wanting sex?
fear of miscarriage.
Okay. Anything else? Then shall we go trimester wise? So in the first trimester, what is stopping her? There's fatigue. Like I told you, fatigue is the star of pregnancy. It's the star symptom of pregnancy. There's going to be nausea. Now, not every woman has nausea or vomiting in pregnancy. A lot of the pregnancies I'm seeing these days does not have nausea, does not have vomiting. They have a lot of gastric issues, but not so much vomiting. Nausea, yes, more common than vomiting. There's a fear of miscarriages, especially common if there was the delayed occurrence of a cardiac activity, if there's a history of miscarriages. Sorry. Then poor awareness. This is again a very, very common fear, a very common factor that comes into play when we ask women that why did you not have sex? What's stopping you? And so they say that we didn't know we could have sex in pregnancy. We literally didn't know that. We thought you are not supposed to have sex in pregnancy. That you had sex, now you're pregnant, and that's it. You're done. You cannot have sex in pregnancy. So that is poor awareness. Then low energy. Like I told you, they don't feel fresh. Pregnancy will not make you feel fresh on majority of days for a lot of women. For many women, it's a dream. For many women, it's the pregnancy glow. And then these women are glowing and they actually have really good days. Then abdominal cramps, the period-like cramps, especially in the first 3 months, especially in the first trimester. This settles down in the second trimester. Then the uterus is actually in the pelvis, sitting on the bladder, making the woman run to the toilet to go urinate again and again. She drinks a little water, and every time she gets up, she has to go to the toilet. So that is because the uterus is lying on the pelvis. It is putting pressure on the pelvis, making her feel like urinating again and again, adding to the fatigue, adding to the entire pregnancy experience. Vomiting. Emotional vulnerability. Once you're pregnant, your hormones and this feeling and that knowledge that, oh, I'm pregnant, and then the hormones, no, I'm supposed to be moody and emotional. And whenever you cry a lot in pregnancy. You feel like crying a lot. You feel low a lot in pregnancy. It's very normal. It's very common. Because of this emotional vulnerability, it can impact your relationship with the others in the family. You'll get hurt easily. It's difficult to recover from the hurt, and you feel like crying. You'll also feel a lot of gratitude. You'll also feel very blessed and lucky. Again, these are variable symptoms. These are subjective feelings. So you have to be careful what patient is feeling which emotion. An accidental pregnancy is not going to elicit the same happiness that much awaited for pregnancy is going to make a woman feel. So understand the emotional background of a patient before you attribute the cause of fear in that patient, right? Then, in the first trimester, what actually happens is sexual drive decreases and the frequency and intensity of orgasms remains unchanged. Even if they have an orgasm in the first trimester, whether it's masturbative orgasms or sex with a partner orgasms, it's going to remain unchanged. The intensity and the frequency is going to remain unchanged. These are clinical findings from studies that have been conducted on couples who were pregnant. So these are the findings, and those were the reasons. Now we come to the second trimester. Second trimester, like I told you, is the honeymoon phase of a pregnancy when it comes to sexual health. There's breast tenderness, there's weight gain, and darker areolas and nipples. So the majority of women who think that it's not okay to have sex while knowing that they can have sex is body image issues. So for a lot of women, breast tenderness and the appearance of the breast, the areolas, the nipples, the weight gain, which starts in the second trimester, early on in the second trimester, that can be a factor in avoiding sexual activity, avoiding the partner. And the couple is adapted to the pregnancy by the second trimester. The physical discomfort, the nausea, vomiting, all that has settled. They have accepted that, oh, we are pregnant, oh, we are having a child. So by then they are relatively okay with it. And the sexual drive is increased in second trimester, which is why it is the best trimester to have sex. Now we talk about the third trimester. There's fatigue. Like I told you, fatigue is also there in the second trimester, but still the second trimester can feel better. There's lower backache in the third trimester because of the lumbar lordosis. There's the belly, which is really protruding outside, and the woman is not able to look down and see her feet. There's lower backache. And then there's the fear of inducing labor, a very real fear that if they masturbate and if they have sex, what if they start labor? What if it becomes an early labor? Or what if the child that comes out has something wrong with them because we had sex and because the baby had to come out early? Then growing pressure on the uterus. Now, in the second trimester, the uterus actually stays in the abdomen. So it doesn't fall or it doesn't cause all that load or all that pressure on the bladder. So there's in the second trimester, there's a lot less running around in the toilet, there's a lot less running to urinate. But in the third trimester, because the baby is grown and because the uterus is heavy and big, it is going to fall on the bladder. There's a lot of pressure on the bladder, and the woman is going to want to urinate again and again. So that first trimester problem is back again. Then there's something called as Braxton Hicks contractions. So these are actually the uterus preparing for labor. So they can feel like contractions, very mild or early contractions, but they settle down on their own. So in a normal pregnancy, in an uncomplicated pregnancy, what is going to happen if you masturbate or if you have sex and you're in the third trimester? You might feel contractions, which basically orgasms can stimulate Braxton Hicks contractions, but these are harmless. They don't do anything. They are normal contractions and they settle down. It is not going into labor. But the first time a woman has sex in the third trimester and she experiences these contractions, it can stop her from having sex again because those contractions can feel scary that, oh my God, I have initiated labor. I'm going to deliver, or the contractions have started. It can feel scary. That is why. So you just have to counsel them and tell them that no, you're all right. It's fine. These are just contractions, and you have to teach them how to monitor these contractions, and they are not increasing. It will settle down on its own. You have to teach them how to understand that. Swollen feet, a beautiful part of pregnancy. No footwear will fit you. Parenthood anxiety. You're going to be new parents. There could also be the sibling anxiety. You have one more child or two more children or any number of siblings, and how are they going to adjust with this new child? You might be worried about the age gap. You can be worried about, oh my God, we are still kids. How are we going to deal with a child of our own? It can be very scary. That is parenthood anxiety. And apprehension anxiety, that you might have had a bad experience before, or you worry that what if I'm not a good mother, what if we are not good parents, what if we repeat the same things that hurt us, we repeat the same things with our child, what happens then? Body image issues. By the third trimester, your body is no longer your body. Your body has changed significantly. You won't recognize yourself. It is probably the only time in your life you're going to look like that, because even if you have another pregnancy, you are going to look different. So third trimester, what happens is there's a marked reduction of coital activity. There's almost a non-existent desire. You're so busy with the heaviness and all the other symptoms that there's no place for sexual desire. For a lot of men, though, their wives in the third trimester is an extremely exciting and extremely attractive figure. They worship their partners as if they were goddesses. So the frequency of and intensity of orgasms decreases. Now, in the first trimester, the frequency and intensity of orgasms does not get affected. It stays the same as a non-pregnant state. But in the third trimester, the frequency as well as the intensity goes down. Again, it adds to the I don't want to have sex. It's not going to be, it's not going to be so much fun anymore. So it adds to that. But the need for physical intimacy, the cuddling, caressing, the casual hand holding, the casual kissing, all of that increases. Obviously, you need love and affection in the third trimester. Okay, so do you know women are often scared to masturbate in case they start uterine contractions, in case they start labor? So while masturbation and nipple stimulation are often used to elevate oxytocin levels in the labor room. So that's a very nice, interesting fact. Now, unmute yourselves and tell me, can a pregnant woman masturbate?
मैम ह्यूमन मास्टरबेट कैसे करती है?
A woman masturbates by using her hand and using the clitoris. You stimulate the clitoris and a woman can masturbate. There is no need to insert anything. You can masturbate without penetration. So now, can a pregnant woman masturbate?
Yes, if not
Yes,
contraindicated.
Yes. If not
Absolutely contraindicated, she can masturbate. Very good. Nice. Some people are paying attention. Nice.
मैम
All
एक
right.
क्वेश्चन और
So, please tell me.
मैम कहना ये है कि वो जब ओवेरियन साइकिल चलता है और यू मेंसुरेशन चलता है तो उस ड्यूरेशन में हार्मोनल इम्पैक्ट पड़ता है क्या बॉडी पे कि यू मतलब सेक्सुअल डिजायर फीमेल में हो और मैस्टरबेशन करे, ऐसा क्या हो सकता है जब बेबी
Uh,
कंसीव मदर के यूट्रस में, तो उस ड्यूरेशन में
okay.
टेस्टोस्टेरोन, प्रोजेस्टेरोन, ल्यूटिनाइजिंग हार्मोन और फॉलिकुलर स्टिमुलेटिंग हार्मोन सेक्रेट
Mm-hmm.
होता है और सेक्सुअल डिजायर हो सकता है क्या?
Sexual desire is very common in pregnancy, and the hormones that you're talking about, the progesterone, FSH, LH, FSH, LH ka role is different, and progesterone is the pregnancy maintaining hormone. So what happens in pregnancy is, depending on your symptoms, your desire will get affected. And it is not the role of these hormones to cause desire in pregnancy. That is a subjective feeling. Of course, they contribute, but it is not the role, the main function of these hormones. They will simply contribute to it. Then, okay,
ओके,
now
थैंक
you're welcome. Now let's talk about absolute contraindications. This is very, very important for any doctor. Like we are talking about, yes, sex in pregnancy, you can have sex in pregnancy, but let's talk about the condition. The conditions apply unless contraindicated. So these are the contraindications. If you have bleeding PV at any week of pregnancy, mostly you see this in first trimester, you tell the patient to be careful. You tell the patient to not have sex throughout their pregnancy, or at least till this has settled down. Bleeding PV is more common, because it could be a sign of threatened abortion. It could be a sign of the risk of abortion, risk of miscarriage. So you have to warn the patient that when most of these patients, if you ask a history, you will see that they had sex and then they had bleeding. So you can ask a history, but don't be judgmental about it. Be very casual, relaxed, gently ask the history. Did you have intercourse before she had bleeding? It's totally all right. It's all right. Nothing is going to go wrong, but we do need to know because sometimes there are genetic reasons for bleeding PV. So if the reason is simply them having sex and then just a risk, so we treat them accordingly. We talk to them, we counsel them accordingly. But if there's a history of miscarriages, that is different. If they have had a previous history that no, there was no intercourse and there's just bleeding, you need to keep that in mind. Then there's the history of preterm labor, the risk of preterm delivery. There's the risk of miscarriage or history of miscarriages. The cervical incompetence. You've seen the cervical length is short. You can see the cervix is opening up, even in the later on trimesters, like second trimester and third trimester. You can see cervical length shortening on the ultrasound. You have to warn these patients. If there's a history of N-wiring or cerclage being done in this pregnancy or any previous pregnancy, that is a sign of history of cervical incompetence. Then placenta previa, a low-lying placenta. The placenta is highly vascular. You go and do penetration then. It's going to cause bleeding. So you can't risk it. Not in placenta previa, not at all. An absolute contraindication. Then amniotic fluid leaking, that is leaking PV or premature rupture of membranes, the history of premature rupture of membranes, preterm premature rupture of membranes. Be very careful when you're taking history. You need a very good obstetric history to be able to tell the patient that yes, you can have sex because you need to rule out all of this. Multiple pregnancies, obviously, bad obstetric history. Then there's something called as relative contraindication. So now this is a case-to-case basis. Like I told you, if they have a history, you need to assess. And if the patient had bleeding PV in the first trimester, early in the starting months, and then they took care and there was no more bleeding and the patient was fine, then in the second trimester, if they want, they can engage in masturbation or penetrative sex. So now let's talk about myths. There are some great myths, and a lot of them are culturally and traditionally contributed. So, sex causes miscarriage. Now, this carries some weight because it does happen, but not in all pregnancies. Penetration harms the baby. The ejaculation, the semen that is going inside the mother will hurt the baby. No, it doesn't work like that. But still, tell your patients if you're having sex in pregnancy, please use a condom. Yes? Then, orgasm triggers labor. It does not trigger labor in every pregnancy at any stage. Maybe towards the end when you actually need it, it might help. Then, cultural and traditional misinformation is asking the husband to stay away from the wife. The wife is kept company by the woman of the house. Oh my God. She needs her husband. She needs her partner. The two of them have made a baby. It's not the women of the house alone who have made the baby. It's the husband and the wife. Please keep them together. Absolutely not indulging in sex. No matter what, you cannot have sex. No, it doesn't work like that. Talk to your doctor, see if it's possible. Fear of harming the baby. Again, that is a cultural or traditional role. So, how does a doctor who is sexual health aware help pregnant ladies? So, now I was a doctor who was not sexual health aware when patients used to come to me and I did not know how to help them. So, which is why I did multiple courses and I was very interested. So, how do you become a sexual health aware doctor? You do courses, you learn from people who have already learned this stuff, and you help the many women out there, you help the men out there. Also, did you know 95% of patients who come to a sexologist are males? There's only 5% of patients who are female. I'm talking about online consultations. Imagine. Then what can you do? You can do sex education. You can inform them of their bodies. You can tell them how it works. You can tell them what they can do to have a pleasant, gentle sexual experience. Love making. Precautions. What precautions should they use? They don't have to apply too much pressure on the abdomen. They don't have to do unnatural poses, anything that would strain the mother's body. And be gentle, be very gentle, use a lot of lubricants. Permission giving. Permission giving is basically letting the couple know. You'll learn more about this if you join the course. You'll learn more about permission giving in sexual medicine. It's a very, very important aspect of therapy, of psychotherapy. You tell the patients that it's okay to have sex, that it's okay, and this is how you do it. So you learn a lot about that. So permission giving is very, very important. Even in a doctor's office, it is important. Again, you only give permission when you're sure that the patient does not have any contraindications. Positions, extremely important. So, what positions can the couple use in pregnancy? You should be aware. You should be aware, especially as somebody in the field of medicine and dealing with pregnant people, you should be aware. It's also a good information to have when you're talking to your friends, when you're talking to relatives, talking to neighbors, because when you're a doctor, people will not look at what your MD is. They will simply approach you and they'll simply ask you questions. And then when it comes to sexual medicine, most of the times we don't have answers. So maybe, now you can. Perineal massages, very important, extremely important. Perineal massages in general help a lot for a lot of sexual dysfunctions. They are very, very good for couple bonding, and it is extremely important for normal delivery. Normal delivery, let's not call it normal delivery, vaginal delivery. Perineal massages are also very useful in vaginal deliveries. It is also a very good experience for the couple to indulge in perineal massages because it bonds them together. It's a very sensual sexual activity, even with or without penetration. Perineal massages are a very good couple activity for pregnant people. Lubricants, your best friend. When you're sexually active, lubricants are your best friend. Psychosexual counseling, obviously, you need a sexologist for this, or you need a good therapist for this. Psychosexual counseling is basically they will guide you how to have sex. They'll guide you what restraints you need to hold while having sex with a pregnant woman. How she can indulge in masturbation, what are the limits, what are the boundaries when it comes to sex in pregnancy. Condoms, so you can avoid infections in pregnancy. A pregnant woman is more vulnerable to infections, so it is all the more important that you use condoms and not give her new infections to deal with, because any sort of vaginal infection will also increase the risk of chorioamnionitis. Might be, the baby might get affected. The chorionic membranes, the membranes inside the uterus can get infected. It can lead to preterm birth. It can lead to oligohydramnios, reduced liquor. So, let's not take the risk and just use condoms. Physiotherapy for lower backache. Physiotherapists are also very good at guiding people when it comes to the pelvic floor. So, pelvic floor relaxation. Physiotherapy, women, Kegels exercise. No. When we talk about physiotherapy in sexual medicine, we also give equal importance to the relaxation of the pelvic floor. Then, what are some recommended positions in pregnancy? The side lying position really takes away the pressure from the abdomen. Obviously, she's in her most comfortable position. She's in her sleeping position. Woman on top, it's enjoyable for her. There's no pressure on her abdomen. She's in control. She's the goddess. The husband gets a nice view, and the wife gets to be in control and pace herself accordingly based on how tired she is or how fast she wants to go. Modified machinery. Modified machinery helps more clitoral stimulation. It is also a very good position for pregnancy. Basically, the important aspect of giving information in positions is to teach them how to not apply pressure on the abdomen. Very important, very important. It's very uncomfortable when the abdomen is pressed or when there's pressure on the abdomen during pregnancy. And comfort and communication are key, whether she wants it and how does he feel about accommodating her. The partners have to accommodate each other. They have to be very comfortable, very open communication, extremely important. The entire pregnancy and postpartum needs open communication and education on safety and sex in pregnancy for the mummy and papa to not forget that they are also husband and wife. It is extremely important. Communication is key, seriously. Then these are some of the nicest things that a pregnant woman has heard from her partner or from her family. So coming home early from work, preparing breakfast for her, bringing her favorite flowers, favorite chocolates, taking her to some place where she wants to go, maybe the temple, maybe her mother's place, maybe some romantic place where they've been before. Then the other child, if there's a previous child, the child being nice to the mother, the child loving the baby inside, then her own parents giving her comfort, her own parents attending to her, and even the in-laws, the husband's parents, bringing her comfort, doing nice things for her, showing her that they care. So all of this keeps a woman cared for, shows a woman that she's loved and cherished when she's pregnant, and that keeps her happy and that keeps her desire afloat. So, in the first trimester, what do you have to teach the partner? What do you have to teach the family? What do you need? You need emotional support. You need a lot of care. Gentle caressing and cuddling is okay. Acknowledgement and awareness. I know it's hard for you. We'll get through it together. A lot of patience from the partner and the family. Assistance with daily chores and typical gender roles. So, assistance with daily chores and typical gender roles would mean that there's a lot of work that a woman handles on a daily basis. So if she gets help with that, her fatigue, her worries, her daily efforts are assisted, she feels cared for. So this is one of the basic lines that we tell our patients, all our patients, not just the sexual medicine patients. I tell all my patients, all the pregnant couples, you have to share your roles, you have to share the chores because now she is busy building a baby. What can you do in the second trimester? So, like I told you, in the second trimester, the uterus grows and is now in the abdomen. So it's a really nice and comfortable time for the mother. There's less of the stretchy pain, there's less of cramping. She has accepted the pregnancy. She has hope for the future. The first 3 months are kind of scary, like there's the risk of miscarriage and should I tell people or not? And in the second trimester, there's a little baby bump and there's emotional intimacy with the partner. There's a lot of comfort because she's able to eat. Finally, she's able to eat. The nausea and vomiting have settled for majority of women, and there's a sense of empowerment, that mother wali feeling, that I'm going to be a mom and I'm making life, and that is a really nice feeling. The honeymoon of pregnancy, it's called, and there's better blood flow to the pelvis. Now, from a clinical standpoint, there's better blood flow to the pelvis, which is going to cause increased arousal, increased lubrication. And obviously, that contributes to a pleasant sexual experience and it is going to reinforce sexual desire. In the third trimester, the most you can do is give her emotional support and continue doing the good things that you've been doing for her and wait for the delivery to happen so that the mother is finally free and then both the parents get to take care of the baby and it's not just the mother dealing with a very big belly. So now we talk again. I want you to unmute yourself and answer me. Should you have sex in pregnancy? Somebody's asked you. So what are you going to do first? You'll grant permission. Okay, go have sex. Or you'll tell them to sleep in separate rooms. No, no sex. Or you'll assess whether sex is safe for the couple. Or you'll say no because why take a risk? If something happens, it's on the doctor's side, right? You told them that, okay, you can have sex and then something happens. So what are you going to do? You can unmute yourself and answer.
Option C, assess whether sex is safe for the couple.
Thank you for listening. You were listening the whole time. Yes, you're right. It is assess
Option
whether sex is safe for the couple. Any
assess
other?
whether
Does
C is
anybody?
correct.
Yes, yes, C is correct. Nice. Okay, so C
C
is the
is
correct
correct.
answer. Yes, C is correct. But may I tell you, for a lot of couples, doctors themselves say no. The husband asks, shall we have sex? Can we have sex? And the doctors say no because we are unaware, because we used to be unaware. We didn't know. If I say yes, okay, yeah, go on, have sex, and something bad happens, what if they come back and tell me, you said we can have sex and we had it, and now this has happened, she's bleeding. So is it the doctor's fault? It is not the doctor's fault, especially if you've assessed them. So the correct answer is you have to assess whether sex is safe for them and then go ahead with it. And then you can tell them, keep maybe withhold for some time. She might have bleeding. No, she has hypertension, so it is going to negatively impact her. And she has a lot of vomiting, so maybe withhold for now. You look at the reason, you give them the reason, you give them information. The patients that come to us are actually wise. They are very knowledgeable. They have Google, they have AI. So you have to give them information. You have to tell them why it's not okay, right? And when it's okay, you tell them, yeah, it looks good, and let's keep working on this. We'll keep assessing. And in case we think it is not okay at any follow-up, we'll let you know. Now, look at this 33-year-old. She is a second gravida. So she has one child and she's pregnant again. So she has a history of gestational diabetes and she's currently at 15 weeks. She's in the second trimester. There is no other significant history. And diabetes is relatively controlled. Now, can this patient engage in gentle lovemaking and sex? Can she engage? Oh, yes, non-penetrative
Yes.
only, and very nice. Yes, she can.
Yes, yes, she
Nice.
can.
Yes, yes, she can. She can. Because it's gestational diabetes, it is not considered an absolute contraindication for sex. But like I told you, we will keep telling all our patients that we will follow up. If you're having sex, you can have sex when it is your green signal, right? The doctor gives the green signal. So, but if at all we look and see that maybe it may not be safe anymore, we will inform you. And you can ask us at any time if you have any doubts. Be very open with your patients about sex. Then do not randomly say, if your doctor has not stopped you, go on, have fun. You cannot say that because unless you yourself have assessed the risk. Basically, I'm trying to say that you need to be careful because when you are giving the green signal, you should be sure that the patient does not have any of those absolute contraindications. Now, healthcare practitioners don't commonly talk about sex to pregnant couples because for a lot of people, it's, oh, okay, they are pregnant now. Okay, no, so the husband and wife are not going to be physically intimate anymore. No, you can expect them to be physically intimate. You should expect them to be physically intimate. It's a very special time. And why would you miss out on physical intimacy? Physical intimacy is not always sex. It is just one part. A lot of physical intimacy is cuddling, caressing, holding hands, going walking together, massages, so many things. Why not indulge in that? Penetrative sex is not the only physical intimacy that happens. So, assess the patient, explain the importance of intimacy and bonding with or without sex. This is important because sometimes when we tell the patients, no, you cannot have sex anymore, the husband does not touch the wife and the wife feels very unattended. So you have to teach them intimacy in the right means and the right limits. That is important. That is also your job. So sex and lactation. What happens when we talk about postpartum mothers when the baby has come, or maybe the delivery did not go well, maybe there was something wrong with the child, and a mother has lost the child. Then be sensitive, be non-judgmental, and then talk to the patient. So sexual activity has to be restarted only after 6 weeks, post delivery, 1.5 months. The child is 1.5 months and above. For a lot of couples, sexual activity does not start until much later. The mummy and the papa are so tired that there's no sex. It is very common, part of parenthood, right? But you can tell them, you can give them the right information that you can have sex after 6 weeks and teach them about contraception. You have to teach them about contraception. We have couples coming in with the 4-month-old child. We are pregnant again, and there's a CS before. So you have to teach them. You have to be very careful when you say, okay, you can have sex now. Be sure to teach them about contraception.
The gap between two kids. Okay. Then the mother has to be treated like a goddess. Be very careful to teach the partner to respect the mother's body, that her body is still changing. It has changed forever and it's still changing. There's going to be stretch marks. Treat those stretch marks like battle scars. You are not going to treat them like your body. This was so tight before. No, no, not at all. So teach the partner to be very gentle, to be very loving towards the mother, and always by preference of the mother. The mother may be tired, the husband comes home, he wants sex, she's not ready. Doesn't work like that. That is going to lead to sexual avoidance. So be very sure that the mother also wants it. Okay. This is true of any circumstance, regardless of pregnancy, postpartum, at any stage of life. It is important that consent of both partners, the desire of both partners should be there. What issues can a couple face when they are postpartum? There could be privacy issues. They are worried about having sex in front of
Baby is asleep, baby will cry, baby is not really going to remember. But still, that privacy and there's somebody else in the room, even if it's their own baby, can be, it can be awkward. Then fatigue and postpartum blues or postpartum depression, very serious, should be considered.
at it. Low libido is also a sign of feeling blue, of depression. So be very careful to differentiate whether it is simply low libido because the mother is tired or low libido because she is heading towards postpartum depression. Resentment. The mother might be resenting the father for his useless nipples, for not helping out, for not being awake at night. It could be any number of things. Resentment by a new mother is very common. So you have to deal with it. Again, a lot of partner education, a lot of education for the mother as well. That's he might be tired, you are tired, sleep cycles are disturbed. Unsolicited advice. Tell them to stay away from unsolicited advice. No, no, the baby is small. You should stay in a separate room. Don't disturb the husband. He's tired. He has just come from work. Nothing doing. Husband wife will sleep in the same room with the baby. They will both take care of the baby and they will not resent each other that way. These are small tips and tricks that you have to tell the patient's family before you tell the patient. Then conception friendly positions. Now, because we are on the topic of pregnancy and sex, I included this also. So, conception friendly positions where you need good penetration, you need good orgasms by both the mother and the father, mother to be, father to be. So, that is missionary, basic. The woman lying down, the husband on top, the partner on top, sorry, and rear entry or doggy style as it is called. Then reverse cowgirl. Again, premarital counseling also includes ultrasound for the mother to be. So if you find out that the woman has a retroverted uterus, it's quite common, not very rare, but yeah, we do find retroverted uteruses. They do conceive easily, but the routine positions, that for example missionary, for example cowgirl, can be difficult for somebody with an anteverted uterus. For a normal position, commonly positioned uterus, the uterus lies like this. For somebody whose uterus lies like this, well, for example, this is the cervix and the uterus is retroverted, we'll have to look it up. I cannot explain it with my hands. So retroverted uteruses prefer reverse cowgirl positions. It is if they have sexual pain, you will not see sexual pain, or you'll see reduced pain when it comes to reverse cowgirl. Other things, other tips that you can explain to patients about conception is you can use a pillow under the hips to tilt the pelvis. Do not wash immediately after sex. You can wait for 10 to 15 minutes. Wait, give some time to the sperms to head inside upstairs, and to not take any pressure or stress about the baby, about the whether the baby is going to have
The period is going to come or not come. Did we conceive? Did we not conceive? Stuff like that. Then what
advice can you give? Can I give to you guys? Always assess risk before giving the green signal for sexual activity. Very important. The mother's comfort comes first. obviously. Communication between the partners is key. Communication between the doctor and the couple is equally important. Routinely, we say avoid sexual activity in the first trimester or in the first 3 months, but this is there are conflicting reports for a lot of couples where everything is normal. We don't see any red flags. We let them have sex, but routinely to avoid risks that we might have missed or that any impending risk, because the risk of miscarriage is common in the first 3 months. A lot of doctors advise to avoid sex during the first trimester, and we just tell them that you can go ahead in the second trimester, it's fine. Be aware of contraindications. Be very aware of the absolute contraindications, because you don't want to be giving wrong advice when it comes to pregnancy. And know what your patient wants. Maika is the mother's house. Maika is the Hindi word for mother's house. What if the patient wants to go to her? I had this patient, had this patient, she was like, please don't tell my husband that it's okay to have sex, because I want to go to my mother's house. Now if you tell that you can have sex, he will not let me go to my mother's house. So have a one-on-one talk with the mother also. What if the woman herself is uninterested in sex? Pregnancy is not the time where you deal with of sexual avoidance, where you deal with, okay, let me teach you how to enjoy sex. Pregnancy is not the time. You can do that later. If she's genuinely uninterested, she's genuinely, no, I don't want to, I have sexual pain, I'm not interested for now, I just don't want to, full stop, period. You don't have to pressurize a mother that, no, no, you'll enjoy it, no, no, it'll be fun. No, you can't do that. Don't do that. It is, if whatever the mother wants, if she's okay with it, good idea. If she's not, leave it. Any questions? Do we have any questions? Okay.
I see somebody has asked a question. Is there any steps or factors that help get the sex of a baby? If somebody's told you that doing having sex in so and so position, you'll get a male child or you'll get a female child, it's all wrong. It doesn't work like that. I also hold an MD, a postgraduate degree in biochemistry. I am very strong in genetics. I can assure you it does not work like that. You cannot determine the sex of your baby. You cannot decide it. If depending on the position that you have sex in while conceiving.
मैम एक पेशेंट है, मेरे फ्रेंड की वाइफ है, उसका AMH
Okay,
बहुत लो और वो बेबी को
okay,
कंसीव नहीं कर, और
okay.
मेंस्ट्रुएशन 3 से 4 महीने डिले होता है और वो क्लॉटिंग ब्लड भी आता है, तो उस ड्यूरेशन में मैम उसको क्या एडवाइस करें और
Mm-hmm.
कैसे
For
कांटेक्ट करें?
someone like her, we should advise
मैम
a very detailed, a very thorough uh, infertility profile, but not immediately. पहले semen analysis देखो, उनके periods regular करो, and उनकी
We can
बाकी
see
reports
for
देखनी होंगी.
DFI. And we can
Yes,
also see DFI.
yes, yes, yes. मतलब you need a lot of reports, you need a lot of assessment basically, because ऐसे directly you cannot label somebody as infertile. But हाँ, AMH कम है does not mean she will not conceive. AMH can be variable. It's not a fixed, जैसे अपने blood group की तरह fix नहीं होता AMH. It is variable, and but yeah, it does indicate कि थोड़ी तकलीफ है. Like it is the sign of quality of the eggs. So they will need further assessment for sure, for sure. Babies हो जाते हैं. But
कैसे
sometimes it
कांटेक्ट
takes
कर,
effort.
आपसे कैसे कांटेक्ट हो पाएगी विथ रिपोर्ट के साथ?
हम अहमदाबाद में हैं, तो अगर वो अहमदाबाद आते हैं तो आई एम द सेक्स थेरेपिस्ट एंड द सेक्सोलॉजिस्ट. हाँ जी.
टेली कंसल्टेशन हो सकता है क्या मैम?
ऑनलाइन करना है तो ऑनलाइन हो जाएगा आपको, बट
ओके मैम,
वो आप हमसे पूछ सकते हैं. आई थिंक मेरा हॉस्पिटल का नाम स्लाइड पे है, तो आप वो हॉस्पिटल ऑनलाइन ढूंढेंगे, यू विल गेट इट.
ओके।
एनी क्वेश्चंस? डू यू गाइस वांट टू टॉक यार? व्हाट इज दिस? कब से आई एम ओनली टॉकिंग.
Thank you for this
Regarding
wonderful
the
session,
postpartum
ma'am.
period,
हाँ. Yeah,
sorry,
regarding the
I thought,
postpartum period.
yeah, postpartum. In the slides, you said about the 6 weeks postpartum to avoid
Mm-hmm.
sexual intimacy. But if the
Mm-hmm.
mother feels comfortable in engaging in sexual activity within that 6 weeks, is it? Can we say it's okay, or um, should we still wait
When
for
if it is
6 weeks
a
to?
cesarean section, we can allow her to masturbate. We can allow her to indulge in sexual activity. It could be oral sex. It could be mutual masturbation. But we tell them to withhold penetrative sexual activity. It could be a little hard on the healing suture. If it's a vaginal delivery, even then. If it's a cesarean section, even then. So we do tell them to avoid penetrative sex in the first 6 weeks. They can masturbate, they can, they can do mutual masturbation, they can have oral sex. That's fine.
Okay, all right. Thank you.
Um, Perineal massages, any video or images? Yes, there's a lot of information about perineal massages online. Perineal massages can be done by the partner, they can be done by the patient themselves. As a matter of fact, in Japan, I have a patient who is currently based in Japan. So she is pregnant. They give such good classes they have birthing classes, and they teach the mother, they teach the father to be, mother to be, how to give perineal massages, how to receive perineal massages. Perineal massages are good for sexual activity. They are also very good to help the pelvic floor prepare for labor, prepare for the delivery. It relaxes the pelvic floor beautifully. Perineal massages are so good. I don't personally have any video or images myself. You can look it up online. It is even available on Pinterest. It's a really old technique. It's a really old methodology to help uh, labor, to help people who have difficulty with sex. If you have any more questions, I would love more questions. Please talk.
Doctor, this is not a question, but so I'm from Sri Lanka. And is there a professional platform that I could connect with you, say something like LinkedIn or something that you are on,
Yes, I am on
that we could
Instagram as the
establish
Besharam Doctor. I'm also on LinkedIn as Dr. Mitali Srivastava. Of course, you can connect.
so in the LinkedIn, the spelling goes as the same.
Yes, Dr. Mitali Srivastava, as it is on the slide.
Right. Okay. Thank you.
Welcome.
Yeah, Mitali, that was a wonderful presentation.
I had fun.
Yeah, good, good. And I think everybody enjoyed the presentation and made good use of the time.
Yes, sir.
So I don't think there are many questions in the chat box. I think you've addressed most of the questions. So
Sir.
anybody who would like to get in touch with Mitali, can you type your details in the chat box so they can get in
Chat
touch with you
box, of
directly?
course, sir. Of course,
Yeah.
of course, sir. I'm sharing my LinkedIn name.
Also, we
TAVON.
encourage you to join the upcoming course, the basic course in sexual medicine as well as the advanced course. You can go to our website. I've put in the details in the chat box. That will take you directly to the basic course. Essential concepts is the basic course, and you can serve the website. There is a lot of information available on the website, and you can also directly go and register on the website. So ours is a 5-year-old academy, and we have been mainly dealing with infertility and IVF, embryology, andrology, those kind of subjects. But recently we have started, we have ventured into this new topic for us also. But we have got very experienced faculty like Dr. Mitali, is very impressive faculty like Dr. Mitali and Rashmi and others. So I'm sure you are going to benefit a lot if you join the course. So we encourage you to join the course, and Mitali has put in the details in the in the chat box. You can directly get in touch with Dr. Mitali also, or else you can
Sir, I
put in the
would
message
also
in the
like to say one more thing.
yeah.
So what I actually want to tell everybody who's watching, if you want to get into sexual medicine, first do a course like this. So what happens is when you are exposed to a course like this, you get to interact with more patients at when you're talking about sexual wellness or sexual health. And from there, you can decide if you want to get into exclusively into sexual medicine, like Dr. Sarappreet is, like I am. So you can do a course like this to help you understand. It will help you in whatever specialty you are, and then you can go from there. But this is the foundation course that you do. It's very important.
Thank you, Dr. Mitali. That was a useful advice for most of the people who are attending. And actually, there is orientation for any branch you practice, So till the time you learn the basics and whether you really fit in or not will be decided, once you're done with the course and how comfortable you are with the branch. It has to be seen.
वो है. So there's a message. What if a woman has lost interest in sex, not because of pregnancy, but she has no desire for sex? Now, this is a typical case that people like me deal with. We see sexual dysfunction. This could be a case of hypoactive sexual desire disorder. This person will need to see a sex therapist, will need to see a sexologist, and we work in a team. We have physiotherapists, we have gynecologists, we have urologists, andrologists, we have references to all these people, and we give the patient what they need to get them back on track, to let them enjoy a happy, fulfilling sexual life. Because the definition of health, according to the WHO, also includes sexual health.
Very well said, Dr. Mitali. The WHO definition, yeah. I had forgotten that. So, if there are no more questions, we can end the session. And the next session comes up on 8th of Jan. It's approach to a patient of sexual dysfunction, where we'll teach you about the history taking and the physical examination. And it will be taken by Dr. Rashmi Patil, who is a renowned psychosexual medicine practitioner in Maharashtra, in Pune. Right, Mitali, any question in the chat box? Because I'm using a mobile, so I might be missing
No,
out.
sir, there are no more questions. There is a raised hand by Yusuf Tuntia. So if they are available, other than that, I don't see anybody, and I think we can wind up.
Yeah, hello.
You can also ask your questions in the demo group, in the demo group which you have joined for joining this class. You can directly, ask your questions in that group, and Mitali will be happy to answer. All of us will be happy to answer.
Sure.
Yeah, hello, ma.
Hey.
Yeah, this is UC. Thank you very much for the great opportunity and the presentations given. I would like to inquire on the exercise you made mention in pregnancy. At which time is it necessary to start? Is it the first trimester, second trimester, or the last trimester? And if that's the case, does it have differences with regards to Nagel exercise during the last stage? Thank you.
Okay. Antenatal exercises are actually started early on. We don't pressurize the patient too much in the first 3 months because they're already so tired. But second trimester onwards, we actively encourage them to start exercising, to start working out, to start taking care of their pelvic floor. And second and third trimester, it's extremely important that the patient takes care of the antenatal exercises, does them regularly to prevent backache and to have a really good labor if it happens. Mostly labor does happen, and antenatal exercises help with that as well. I hope that answers you.
Yes, please. Thank you very much.
I think we are done, Saraprit sir. So shall we wind up?
I'm sorry I was muted. I didn't realize. So, very nicely done session, Dr. Mitali. Are you there? Can you hear me?